Hi, I'm Dove Sinclair with the Power of the Patient Project. My guest today is Dr. Ira Byock, who is a leading palliative care physician, author, and public advocate for improving care through the end of life. He has been involved in hospice and palliative care since 1978. Ira is also the author of 3 books: Dying Well, The 4 Things That Matter Most, and The Best Care Possible. He has also authored numerous peer-reviewed academic articles on ethics and the practice of care. Dr. Byock has been featured on national television and many radio programs. So we are so honored and happy to have this discussion with him today. So welcome, Dr. Byock.
Thanks, Dove. Nice to be with you.
Yeah, so can you first explain what palliative care is?
Well, yes, palliative care is probably the most important medical advance that few people know about. Palliative care is a new medical specialty that focuses on a person who is seriously ill within the context of their families. And palliative care seeks to bring the best care we possibly can to improve the physical well-being of a person, their comfort, their function, but also their emotional, social, and spiritual well-being.
Mhm.
So palliative care is a team approach to care for people who are seriously ill, that again seeks to make the best of what is always a difficult situation.
Right. So what's the difference between that and hospice?
Well, good question. So hospice is actually where palliative care started in the United States. Hospice began in England in the early to mid 1960s, and was really first evident in North America in the early to mid 1970s.
Mhm.
Hospice kind of grew up and finally was funded by Medicare in the early 1980s as a team approach to the care of people who were dying, that address their physical, emotional, social, and spiritual well-being and support for their families. Along in the early to mid 1990s, a number of us, myself included, who were leaders, if you will, in hospice care in the United States, looked around and we said, gee, hospice care is really a brilliant model of care. We're taking people with highly complex needs and improving their quality of life, their family's quality of life. And sometimes, if we look at it, those of us who were doing it noticed that sometimes people lived longer because of the attention that we were providing to their physical well-being, their sleep, their eating, their eliminating, their anxieties, all of that. People were sometimes living longer. And we said, well, this works well. It improves people's length of life, quality of life, and actually costs of healthcare were actually going down rather than up, merely because we could meet their needs at home rather than forcing them to come to the hospital.
Mhm.
And we said, why are we forcing people to be dying to get this? Why don't we just do this for people who are seriously ill? And we created what is now called palliative care, which doesn't require people to be dying. It just requires people to be seriously ill and have something that might be life-threatening, to have their needs addressed and their family supported.
Mhm. Yeah.
So I hope I've answered your question. Hospice has become a subset of palliative care. I have a slide with a diagram where it's a nested circles, right? Uh, all of hospice is palliative care, but not all of palliative care is hospice.
Mhm.
Hospice is basically now partly bounded by the Medicare hospice benefit criteria that require people to acknowledge that they are dying. And by and large, not entirely, but by and large say, I don't want to go to the hospital. I'm going to forego treatments for my disease, the cancer or heart disease, and really just focus mostly on my comfort and quality of life.
Mhm. That
Palliative care doesn't require that, but also doesn't get that Medicare reimbursement that hospice benefits from.
right, right. Yeah. Thank you for clarifying that. So how did you get into all this? How did you get into palliative care, and what, like, sparked your interest to even start advocating for these type of things?
I've been doing this for a very long time. I'm an old family doc. I started medical school in 1974. Started my family practice residency in 1978, and at the time, I really thought I was going to be a rural family physician. So I learned cradle to grave medicine. Whole patient and family life cycle, developmental stuff, and all of that wonderful stuff that draws clinicians to a family practice, and which is still kind of the way I look at the world. Um, During that time, I was in a training in a hospital in Fresno, California, very good but very busy safety net hospital, caring for many, many people who were uninsured.
Hmm.
And I realized that our hospital did a great job of caring for people, but when they were acknowledged to be dying, it seemed like we pulled back and gave them kind of short shrift. I thought that was both a lapse in our medical quality, but also sort of a social injustice. Like, when did they stop caring? When did they stop mattering? They're just folks. They're just, we're all mortal. None of us gets out of this one alive, and so they're just folks. And there's a lot we can do to improve their quality of life and their family support. In doing that, I helped create a little hospice program. This is during my residency, just to make sure that people didn't get lost in our health system once they left the hospital, making sure that we were kind of coordinating things, that they knew who was going to fill their prescriptions when they needed refills, and
Hmm.
the nurse could find them, the home health nurse, all that. And we solved a lot of problems. We prevented a lot of problems. That was really very satisfying. But what drew me to this field was that in preventing those problems, being able to keep people out of the emergency department, making sure that they didn't get that their pain medications were refilled, making sure that they didn't get so constipated from their pain medicine that they ended up with a bowel obstruction. And I mean, just really simple medical things. Every once in a while, I'd meet somebody who knew that he or she was dying and say, "How are you doing today, Mr. Rodriguez," for instance. And the person would look me right in the face and said, "I'm well, doctor. How are you?" That I didn't have an explanation for. What does that mean? And I thought, Dove, when I first heard that, I thought to myself, well, sure, it's the morphine,
Hmm.
right? They're a little high on the morphine, or, oh, sure, they're euphoric because of the steroids we're giving them because of, a tumor in their liver or something. But I started to realize that this was really interesting, that maybe they were actually choosing their words well. This notion of "I'm well, doctor," this notion that somebody could actually feel well within themselves, right with their families, right with their world, right with their God, even knowing full well that their time was short, that intrigued me
Hmm.
and actually changed my career. Because I realized that as a family doc, that's what I was trying to do for my patients at any stage of life. And while this was an inherently difficult stage of life, what more could I ask than for my patients to be able to feel well, even as they were leaving this life? Whew. So that, you mentioned I wrote 3 books. My first book, which tells the story of how I got into this, starts with my dad's illness and dying. I titled "Dying Well." And that phrase is not just about, well, there's a better or worse way to be dying. You can do it well or you can do it badly. Yeah, that's true. But more, if you think of the word "well" as an adjective, can a person be well? Can they die well within themselves? That I continue to think is the highest therapeutic goal. And that's a very long answer to your question of how I got into this. It got under my skin, and I started to really think a lot about what does that mean? And how can we do that for people? And what distinguishes those people whose suffering we can't seem to touch and other people who, even though they're still, uncomfortable physically, have a sense of well-being concurrent with the strain of their illness.
Yeah.
That has become my career.
Yeah, and I think that's so important. Everyone deserves to, live well and also die well too.
Exactly.
So, how can like a physician say, or a doctor, or even a nurse, like make someone's end of life care better? Like, how can they just like something small? Can they do something small, or is it a big system? Like, what can they do?
So just think about this as another normal part of people's lives. It may not be the most fun part. It's the hardest part. It's awful. Dying, I don't want to romanticize it, but it happens. The first thing that all clinicians need to do is to think about it and make it, normalize it, so that you can talk to people about what matters most to them. This is personal. Illness and dying aren't medical fundamentally, they're personal. But if we don't address the medical, they get stuck in the medical, and they never have those opportunities to do what's most important. So in a very kind of structured way, every adult should have a conversation with his or her primary care provider, firstly, about who they would want to speak for them if they were in a car accident and were seriously injured, couldn't speak for themselves. After the age of 18, it's not clear who that is. It's not your parents. You may be 19, but if the law says it's not your parents, unless you've completed a document that says it is your parents. Right. Who do you want to speak for you if you're unable to speak for yourself? The main way to do that is through an advance directive or a durable power of attorney for healthcare. You can download them from the web. They're really easy. You don't need an attorney to do it. It's free, right? And simple, but that's part of completing your medical record. In the health system I currently work for, Providence Health System, we've made that just part of the medical records, like asking for your allergy list. So that's number one. All adults should have that. When somebody becomes seriously ill, they're diagnosed with heart failure or cancer or dementia, Alzheimer's disease. That needs to trigger a series of goals of care conversations to determine what people's personal priorities are, what matters most to them with regard to how much and what intensity of medical treatments they would want to prolong their lives, rather than to focus mostly on their comfort. Now, you can do both. You can prolong people's lives and focus on their comfort, but at some point in time, there'll be tension between those two goals. And that's important because illness is personal, not medical. I can't go down a disease treatment algorithm and know what the best care is for you until I ask what matters most to you. Two people with exactly the same age, genders, diagnoses might give me very different answers about what the best care looks like for them in this circumstance. One might want all treatments possible to extend life, even if they can't recognize others and can't know visible evidence that they're enjoying life. Another person would say, if I can't read the newspaper and talk to my grandchildren and talk to my spouse, please just focus on my comfort and let me die gently. Both of those are legitimate responses, but I don't know until I ask. So all clinicians, when somebody has a serious diagnosis, needs to ask about that, and then needs to keep asking as people either get better or the disease progresses and they get less well. Those conversations are part of delivering the best care we possibly can to everybody. So those two things, I would say, at some point, when somebody has a serious illness, I'm a big believer in getting second opinions, sometimes third or fourth opinions. I would say if you have cancer or dementia or heart failure or liver failure, get 2 or 3 opinions, but make sure that one of those opinions is with a palliative care doctor or team.
Mm-hmm.
Just not to create either ors. It's about getting both, getting the best care possible for your disease, but along the way having a team that's also focused on your quality of life, your function, your eating, sleeping, eliminating, your enjoyment of life, and all the details of the support for your family.
Mm-hmm. Yeah, definitely. I know you might have already mentioned this, but what are some of the challenges that our healthcare system is facing with end of life care? And do you have like any solutions?
Yeah, first of all, I don't use the phrase end of life care very much at all. I don't know when people are dying. I use the phrase end of life care to look back at when somebody did die, and then I can say this was their end of life care.
Okay.
They spent 3 weeks in an ICU and then died, or they spent 3 weeks at home with hospice before they died, or that's their end of life care. Going forward, it's often hard to know when somebody is dying. They're just seriously ill and their life is at some risk. Um, the our health system in America has multiple challenges. We pay for aggressive treatments, surgeries, intensive care, hospitalizations very well.
Right.
We pay for primary care and things like palliative care far less well. And so guess what? They're harder to staff. They're harder to carve out time for people to get the personal attention that they deserve. Um, and so people have to be advocates for themselves. It's a mistake to think that your doctor or healthcare team is going to manage all your issues around your care and quality of life. They may want to, but our healthcare system is not designed to support doctors and your health team in meeting all your needs without some help from like palliative care or other. So you kind of have to stay an advocate for yourself, finding a doctor and team that you trust and can work with, but always making sure that you're getting that best care, that you know what the plan of care is, that you know who to call in an emergency, that the people you rely on are responsive to your needs, right? Because even with the best intentions, if your or your loved one who's ill is not getting their needs met, you have to know when to speak up, when to ask for something else, when to complain, and when necessary, when to fire your doctor or healthcare team and go to someone else. That's just the world we live in. It's, our commitment should be to get the best care we possibly can, not some loyalty to our health system or clinicians. And it hurts me to have to say that, but that's just the truth these days.
Yeah, it really all comes down to the patient, I guess, having those conversations. I feel like, especially people my age, we never think about these things. So it's like, it's never in the forefront of our minds. I think.
But people your age, for instance, need at least to have an advanced care planning document, an advanced directive on file. If you don't, you're at risk. If you end up in a hospital, your parents or whomever you think should see your medical records may not be able to because of HIPAA.
Yeah.
Right? They may not be able to make decisions on your behalf. And it becomes really important when there has been discord within a family, when there's been a divorce and there's a divided, a blended family, and a 55-year-old man doesn't want his previous spouse or maybe some of his adult children to make decisions on his behalf. Without a document saying that, it's who he would trust and wants to speak for him, he's at some risk. A young adult who is gay and has a lover who she wants to make decisions on her behalf, may not have that ability without just simply creating a simple document
Right.
that says that. So these are really important things that all adults need to pay attention to. I'm not to be, morbid about it. This is just but we are mortal, and if we're going to really be free to enjoy life and live life as we wished in its richness and fullness, we have to at least do some planning for this. It's like having car insurance or health insurance or disability insurance, which as a young father, that was the first insurance I bought, was disability insurance, because I wanted to make sure that if I was unable to provide for my family, they were covered. I have an advance directive, not because I'm physically ill and not because I teach this stuff. I have an advance directive because I have a family,
Yeah.
right? And I know that they're going to wrestle with decisions about my treatment if I have a stroke or head injury of some sort. I don't want, I want them to have the authority to speak for me. I don't want anybody to even be able to question that authority. And I want to tell them a little bit about what I think I would want to maybe lift a little bit of the burden for decision making from their shoulders.
Yeah, definitely. Really important. Thank you for explaining all that. And now you told me that hospice was kind of like a subsegment under palliative
Mhm.
care. What are specifically some of the benefits that hospice can provide to patients?
There's a lot. I often say that hospice care is like home care on steroids.
Hmm.
Home care sends out a skilled nurse that can see patients at home once or sometimes a few times a week, change their dressings if they have a surgical wound that's healing, or a bed sore or something of that nature, or need antibiotics administered, all of that. Hospice provides, yes, a skilled nurse, but also a social worker, a doctor backing up the team who can prescribe for the patient, bath aides, home health aides, people who can come in and in a highly personalized way support the person who has a incurable terminal illness
Hmm.
with their family in the context of their own home, to make sure that their needs are met, their pain and all the biological functions that I keep mentioning, but they're also their worries, their anxieties about the future, all the paperwork that I just mentioned, that's in place, that the family is getting enough rest themselves and has the support they need to continue to care for the person who's ill at home. Um, all of that. It's all paid for. Hospice under Medicare and most insurance plans is paid for soup to nuts. The medications, a hospital bed if you need it, any equipment in the home oxygen if you needed that. All of these aids and nursing visits, all paid for. It's also 24 hours, not in terms of being on site 24 hours unless there's really critical needs, but somebody to answer the phone. You've
Hmm.
got a new symptom that you can't identify and don't know what to do. There's somebody to call who knows you, has access to your chart, your medical record, can get to a doctor to prescribe something if it's needed after hours. All of that's hospice care. It would be hard to describe a system that one would want more in that circumstance. Like, wow,
Yeah.
all of that comes in a single package. Many people, when they're finally referred and admitted to hospice, because part of the problem in the United States is hospice is brilliant, but people are coming to it very, very late in the course of their illness. But many people, once they're admitted to hospice and get to live with that sort of support, say, wow, why didn't somebody tell me about this sooner? Like, this is amazing.
Yeah. Oh, that's a lot of benefits. Would you like to add anything else? Those are all the questions that I have for you.
Well, I think all of us as Americans in this time of a turbulent American healthcare system is changing a lot, and mostly for the better. we have to be advocates for ourselves. We have to think about what matters most for us. Um, you know, we all do eventually face death, and again, I don't want to in any way diminish the personal tragedy that illness and dying always is for oneself and one's family. But it's okay to think about it and prepare for it, and then put it aside, thinking, okay, I've got my preparations in place. If you keep it at a distance because you don't want to think about it, in my experience of being a doctor for over 4 decades, not thinking about it never stopped it from happening, never prevented us from still being mortal and eventually dying. What it does do is make it harder to go through once it happens, make problems that could have been prevented, you then deal with them late. So I guess as a culture, it's time we grew the rest of the way up and recognize that we are mortal. Yeah. And that's okay, that we can live fully as mortals. We're not going to live forever, but we can hope to live fully and be well within ourselves, well with the world, well with our families and the people we love, through the very end of life. Mm-hmm. That's my hope for my patients, and it's my hope for our culture and our country.
Yeah. Thank you for sharing all that. I certainly learned a lot. I will definitely be thinking about how I can start to do some of these things. So ease some pressure off my family and all that future stuff. Because after all, we all do die at some point. So thank you for
Right.
coming on, and it was great having you.
It's a pleasure. Let me say, I do have a website, and I put this out there only because I want to give people as much resources as possible so that they can use them in their own lives. I'm not selling anything. But the website is just my first and last name, Ira Byock, IRABYOCK.org. And most of what I've written, articles and op-eds and even academic articles, when I can, I post on that website, and lots of resources that I hope can help empower people to get the best care for themselves and their families.
Yeah, great. Thank you.